Leonid, perhaps you can start sharing your slides.
Okay, all right. One moment, please. How about now? You can see it?
Yes, we can.
Excellent. Yeah. Thanks.
Okay, so hello and welcome everyone. Thanks for joining us in our research seminars today. Since our usual chair will be presenting his paper, I will take his post as a chair. So let me introduce us our good friend and colleague Leonid Polishchuk, and well, he has a PhD degree or candidate of science, as it's called in Russia, in mathematical and instrumental methods in economics from the Institute of Economics of the Siberian branch of the Academy of Science of the USSR. And well, as we very well know him, he's an economist with research interest in institutions, political economy, and cultural studies. And today he will be presenting his work that is titled Non-Profits versus For-Profits in Social Service Delivery, a Theory and Applications to US Nursing Homes. I think you are quite familiar with the rules about timing and everything, so please, the floor is yours. And just to our audience, please register yourself in the chat with name and affiliation as usual. And well, please, Leonid, the screen and the floor is yours.
Thanks very much, Bernard. Good evening, everyone. Yes, Bernard mentioned this paper about outsourcing of social service delivery to organizations of different types of ownership. Around the world, it's now a common practice, and that although governments maintain responsibility for social service delivery, the actual provision of social services is outsourced to private organizations. And these private organizations initially were mostly for-profit firms because there were strong reasons to outsource to for-profit firms. And that was a part of the general privatization drive, which initiated in the UK at the end of the 20th century. But recently, government's partners in outsourcing are not only non-profits, but not only for-profits, but also non-for-profit organizations. And I do not know of any study that compares these two types of outsourcing. So this paper is intended to fill this gap and also to present some empirical evidence of the main predictions of a simple theory that we deliver. And the application is outsourcing of extended care for elderly people, the so-called nursing home industry. For the Russian part of the audience, if someone spends the final years of his or her life in a nursing home, it's some kind of a human tragedy. But in the West, in North America, in the United States, and Canada, in Western Europe, this is a standard life cycle part. People who reach extended age oftentimes move to special facilities where they receive professional care, medical care, and personal assistance. Because oftentimes these people have different health and physical conditions, and they live much longer. And as a result, it's a rational choice for these individuals not to stay at their homes, but to move to such facilities. And if you look around the world, then you observe that nursing homes are run either by non-profit organizations or for-profit organizations. Sometimes they're also run by governments, mostly by municipal governments. So the question is why these different ownership types coexist in the same market, what are their comparative advantages and disadvantages. So this paper sheds some light on this issue. And also, in addition, it takes predictions of, as I said, a simple theory that I'm going to present to the case of US nursing homes during the time of the COVID-19 pandemics. And I should say that in this project, I'm privileged to cooperate with two colleagues which are present here. One is Professor Michael Alexei from Indiana University, and another one is Ivan Dedukin. So the empirical part of this paper is a joint effort, and I will show this part in due course. Okay. Now, the first thing to mention is that care for elderly people has become a major industry. Population aging, growing life expectancy, and transformation of traditional extended family expand demand for institutional long-term care for the elderly. The recent World Economic Forum report predicts that 40% of the newly created jobs will be in the care economy globally, and second most needed profession care economy is personal care assistant, and this is precisely what is happening in nursing homes. Now, in the nursing home, there are several names for different types of institutions: nursing homes, long-term care, extended care, and there are some subtle differences between them. But for us, the important thing is that there is a special facility, a place, a home where elderly people live, and they receive personal care and medical care in that facility. Now, this is a very expensive service. Cost of professional long-term care for the elderly is quite high, and few people can afford it unless people are very wealthy and can rely on their savings or retirement income. On the average, cost of professional long-term care for the elderly is more than twice the disposable income of senior citizens in OECD countries. And as a result, this service is commonly supported by publicly funded social welfare programs, which in different countries cover anywhere from 50 to 100% of the cost. Well, again, a lot depends on the specific cases, types of institutions, but governments are present big way in this area. And even in the USA, where government, which is not known for being a well-developed welfare state, and where government's involvement in social service delivery is limited in comparison to Europe, at least, or Canada, even in the US, the long-term care industry received a major boost after long-term care became eligible for support by the federal programs Medicare and Medicaid. Now, why do we need outsourcing? Well, very simply because this is a major industry, and it's an industry which is costly to maintain. We observe rapidly growing scale, a rising cost of long-term care, and that happens first because people live much longer. And secondly, because there are now new, more expensive treatment and life-supporting medical technologies. So that makes long-term care a very expensive thing. And as a result, if the government maintains responsibility for long-term care, the government is interested in increasing or improving efficiency for this industry. And because we are skeptical about the ability of government agencies to deliver efficient services due to weak incentives, this is resolved or achieved by outsourcing of long-term care to private providers that might have important comparative advantages over public service providers. Now, when I say private, again, this is important nuance in terminology. Private means non-governmental. And private providers can be basically of two types. One is for-profit providers, another one is non-for-profit providers. And just to be on the safe side, I would like to remind the definition of what is a non-profit organization or provider or entity. It's a private entity, it's a non-governmental entity which delivers services or sells goods or does something, receives income, for example, collects service fees. But and so far it's similar to for-profit organization. Difference is that the main motive for for-profit organizations is to generate profit, and for-profit organizations have owners, and these owners can be corporate owners or private owners or whatnot. But owners are residual claimants. They pocket the profit that this organization generates. Non-profit organizations can also have what we can call profit, which makes it a bit of a misnomer, but this profit would be more like operational surplus. And because this organization has no private owners that claim the surplus is supposed to be reinvested into the organization. So that's the basic difference between the two types of private organizations. Okay, well, as I said, outsourcing to for-profit organizations became very popular in the late 20th century, and that was a part of what is known as the new public management approach, where much of government services were outsourced, privatized, passed on to private providers. And what were the main rationales for this outsourcing? First, because private providers were reliant on market mechanisms and incentives, and we come to believe that this is a good thing. Importantly, because they have very high propensity for innovation, because they are, for the virtue of being for-profit organization, they're quite keen to control and reduce costs, and as a result, either to make this service lesser a burden for public funds and or more affordable for the customers. And last but not least, because they're very flexible and they have the ability to respond promptly to the growing demand. And they're not really capacity constrained, because all you need is to have access to a virtually unlimited venture capital market. Capital market is boundless, and if you want to expand service delivery, but private providers, well, you simply mobilize, raise capital from this unlimited market. Okay, but then outsourcing to for-profits carries significant risks, and these risks are because aggressive cost cutting could negatively affect service quality. And that is particularly troublesome when quality is difficult to verify externally. One can argue that in the case of outsourcing, quality standards and specifications could be included in a contract with the private provider. But there are problems with external control, verification, and measurement, and these problems are typical for credence goods, and many social services are credence goods. And therefore, the contract protection of service recipients in such case becomes problematic, because what is unobservable cannot be made contractible. And under such conditions, there are reasons to avoid outsourcing of a social service to the for-profit sector. And that was the main conclusion of a paper in which my co-authors and myself rely heavily, paper by Schleifer and Vishny in 1997, which discussed pros and cons of outsourcing to for-profits, but without considering non-for-profits. Now, extended care for the elderly is, of course, a credence good. And why is it so? Because immediate service recipients, senior citizens, elderly people, due to their poor physical and mental health, could be, you could argue, powerless and voiceless. And therefore, they cannot effectively complain if the quality is substandard, and sometimes they're not even able to establish that the quality is substandard. And such people are often represented by third parties, relatives, guardians, etc., which cannot immediately ascertain and establish the level of quality. And there are some other examples of this kind of predicaments. For example, childcare facilities, more or less same situation, the opposite to extended care, but same problems. Orphanages, psychiatric hospitals, and also prisons. Prisons were the case considered in depth by Schleifer and Vishny. Now, what is an alternative? Well, an alternative is outsourcing to nonprofits. Outsourcing should not be limited to for-profits only. Government partners in outsourcing can be also non-for-profits. And this approach is a part of a more general approach to how a public sector should be organized, which is known as the new governance theory, as opposed to the new public sector management. And new governance theory suggests that public sector should make use of anything which exists in the economy and society, of various institutions, organizations, and instruments that could be delivered or developed for various purposes All you have to do is to screen what is available and select government partners in outsourcing if there are sufficient reasons to do this. And that includes, of course, non-profit organizations. Now, what are the advantages of non-profit organizations in serving as government partners in outsourcing? Well, one thing is they are closer to the people. They're better informed about needs in the society because they have their own proprietary or exclusive information and communication channels. They better they have better knowledge of the needs and circumstances on the ground. They are able to fill niches and lacuna in demand for social services. That advantage is important because if a social service is provided directly by government, then as any public government decision, they target, this is usually a generic service, and they target the need of the median voter, so to say, but there are a lot of niches to the left and right from the median voter, and nonprofits can fill these niches as opposed to government agencies. Now, nonprofits like for-profits are also known for a greater propensity for innovation and experimentation. Although in doing so, they're relying on different types of entrepreneurship. We usually think about entrepreneurs as what is known for-profit entrepreneurs. These are the people that come up with innovations because innovations allow them to earn extra income to get a competitive edge. But there are also non-for-profit entrepreneurs, people who are driven by the mission and the purpose and by the need to solve a particular social problem. And such entrepreneurs are equally keen to innovate, and that's an important advantage of outsourcing to nonprofits. Now, an important thing about nonprofits and a source of their comparative advantages is that unlike for-profits, they are driven not only by market-based monetary incentives, but oftentimes by the sense of mission and duty. And as a result, they're directly concerned about quality. They internalize quality issues without quality concerns being mediated by the market. Now, if we try to compare service quality from different types of providers, then we immediately observe that consumers of credence services or credence goods could prefer a non-for-profit provider over a for-profit one, because the non-for-profit provider first is less keen to cut costs with a possible detriment to quality, and secondly, take service quality closer to heart, and that provides additional quality assurances. And this is a well-known feature in the non-for-profit literature, both traditional and more recent. And these advantages alleviate the lemon problem, which is, of course, market failures, which occur as a result of unverifiable quality in social service delivery. Now, let's briefly summarize what I said so far by comparing disadvantages or advantages of for-profits and non-for-profits. Now, for-profit providers are driven primarily by market incentives, whereas non-for-profits are motivated by solving social problems. Usually, market incentives are more high-powered, which on the face of it gives some advantage to for-profits. But in the case of uncertain quality, strong market incentives could be a mixed blessing, simply because when markets are imperfect, there could be a significant discrepancy between what is profitable and what is socially desirable. And in that case, market-based incentives could be poor guidance from the social welfare standpoint. And if that's the case, then reliance on intrinsic, emotional, altruistic motivation could be preferable. Okay. So if we are to select between two types of outsourcing to nonprofits and for-profits, our selection should probably depend on the degree of alignment or lack thereof of market signals and incentives with social needs and priorities. And the degree of such alignment varies between different types of public goods and services. And this is why we need some simple theory that would be our guidance in such comparisons. So here is the theory. And the theory is an extension of two important papers. The first one is the paper that I already mentioned, Hart, Schleifer, and Vishny, about the title of the paper is The Proper Scope of Government. But basically, it's a question as to when it's desirable to outsource a social service or public good delivery to a for-profit provider. And then another more recent paper by Glaser and Schleifer on nonprofit entrepreneurs. We follow the former paper in assuming that a service provider can generate innovations. That's the main reason for outsourcing. And these innovations would be reducing operational costs and or improve service quality. And in Hart, Schleifer, and Vishny 1997, there is a very narrow class of innovation that the authors consider. In our case, we consider all sorts of combinations of innovations, and they are described by a general form cost function. I will provide details in a moment. Now, we follow the second paper by Glaser and Schleifer in assuming that although a nonprofit provider is restricted by what is known as the non-distribution constraint, and let me explain what it is. It's a typical feature, it's a legal implication of a nonprofit status. If you generate a surplus, you cannot distribute this surplus to private owners because there are no private owners. And as a result, people who are involved in this non-for-profit organization cannot appropriate, pocket the operational surplus that they can generate, and this is the non-distribution constraint. But Glaser and Schleifer argue that in reality, there are some ways to walk around this non-distribution constraint and appropriate at least a portion of the operational surplus by increasing salaries, perks, non-monetary benefits, so on and so forth. So we make use of that assumption so that the nonprofits are a little bit for profit to various extent. And second, we also assume, and that's quite natural, that nonprofits have some intrinsic incentives to provide quality service in addition or instead of the market incentive to maintain quality. The market incentive to maintain quality could be weak for both types of providers if this is a credence good with unobservable quality, as I mentioned before. But it could be weaker still for nonprofits because market incentives are secondary for nonprofits in any case. Now, let me briefly describe the setup of the model. Suppose that there is a production unit, and we do not specify the ownership status of this unit yet. This unit provides a public service, and there is a basic pattern of this public service delivery, which does not involve any innovations. And in this basic pattern, basic quality is some Q0, which is the unit's contribution to social welfare measured in monetary terms. There is some basic production cost C0, and we assume that if the unit is delivered by a public agency, then the quality will be exactly Q0 and production cost would be C0. The provider gets a basic remuneration service fee, which is P0, and P0 is between the cost and the contribution to social welfare. Now, what is an innovation? Innovation is a couple QS. Q is a quality improvement, and S is the cost reduction. And I assume that both of these numbers are non-negative. So the assumption is that quality cannot be reduced below the basic level Q0. That assumption can be relaxed. It's not really very important. And costs can be cut below C0. Now, the important thing is that to generate, to invent, and to implement this innovation is costly. And there is social, and there is cost, in part tangible, in part intangible, of developing and implementing the innovation. And this cost is C of QS. And we make standard assumptions about this cost function, but the most important of this assumption is that the marginal cost of quality improvement goes up at a higher level of cost reduction. So the second partial derivative CQS is positive. Put differently, it means that it's easier to cut costs for lower levels of quality, and that makes perfect sense. In other words, if you want to maintain higher level of quality, then cost reduction becomes more difficult than if you do it at the lower level of quality. And there are multiple ways to endogenize this assumption and to explain it. One possibility is that two types of innovations, cost reduction and quality improvement, tap the same source of entrepreneurial energy, whatnot, and as a result, they're crowding out each other a little bit, and this is why we have this this condition, which is quite important for what will follow, really key condition, which again, at least to me and to my co-authors, it makes perfect sense. Now, how about market incentives? Market reward for quality could be weak, simply because quality is difficult to observe and measure. And we assume that remuneration, if there is a quality increase Q, then remuneration is only a share of that increase with some epsilon less than 1. And when quality is completely unobservable, when the good is a service is 100% credence good a service, then epsilon is close or equal to 0. Okay. Let's see. Okay, now let's see what are the utilities of providers. And here we have to start making distinctions between for-profits and non-for-profits. Let's talk for-profit first. And for-profit provider, well, it's simple, you know, nothing fancy, just pure profit. And what is profit? Profit is your basic price, P0, plus the market premium for quality, epsilon Q, minus basic cost, reduced by cost reduction S. And of course, the provider has to cover the innovation, development, and implementation costs. So the profit of the provider, of the for-profit provider, is as follows. So it's kind of simple. And now and this is what for-profit provider arguably tries to maximize. Now let's talk about non-for-profit provider. The non-for-profit provider, as I mentioned, can partially convert the operational surplus into material gains with some conversion coefficient alpha less than 1. So the operational surplus is greater compensation net of reduced cost, right? And also the non-profit provider has some altruistic motives. And as a result, that provider receives some direct non-market mediated monetary payoffs. This is what sometimes in the philanthropy literature, this is known as a warm glow effect. You just feel good because you deliver high quality service and you follow your mission. And there is some monetary equivalent to this feeling, which is a part of this provider's utility. And this is quality improvement Q times some coefficient beta. And overall, non-for-profit providers' utility is as follows. This is the converted operational surplus. This is the warm glow. And this is the cost of implementing the innovation. Okay. Now, what is first best? The way to go about this kind of problems is first to have a normative view of the situation and try to figure out what is social optimal, and then see to what extent alternative modes of outsourcing get you closer to what is social optimal. Now, the first best maximizes social net social welfare gains, which is quality improvement plus cost savings minus the cost of developing the innovation. And with standard assumption, that gives the following first order conditions for the first best. Now, let's see what happens with the for-profit provider. As I explained, for-profit provider maximizes this profit function. And again, first best is as follows. And it's kind of similar. Let me spend a minute and draw attention to comparison between these two outcomes. Please observe that the for-profit provider properly incorporates in her decisions social gains of cost cutting. And CS equals 1, both in this case and in the social optimum. But for-profit provider greatly underestimates, underappreciates the quality improvement, because social optimum requires 1 here. And in the case of for-profit provider, it'll be a much smaller number, epsilon. And if it's a completely credence good type service, it'll be simply 0. So is oblivious for-profit provider to quality improvement. What happens in the case of non-for-profit provider? This is the utility, and this is the first order condition. And we can observe that for-profit provider, non-for-profit provider, I'm sorry, sort of undervalues both cost reduction and quality improvement. So none of these options is really first best. It might be worth mentioning, it's a technical note, but these 3 allocations, the first one, first best, and the second one is for-profit provider, the third one is non-for-profit provider, can all be generated by considering an imaginary firm, an imaginary for-profit firm, which produces 2 products, which are 2 types of innovations, Q and S, and with the cost function C of QS. And this imaginary firm sells its outputs, not outcomes, outputs, of course, at some prices, PQ and PS. And now what we need to do is to study supply decisions of such firm in response to different prices of these 2 goods that this firm sells. And the prices would be as follows: for the first best, for-profit provider, and for non-profit provider. Very briefly, let's talk about outcome comparisons. As I mentioned before, in general, neither non-profit nor for-profit would deliver first best. And please observe that for-profits respond to the correct price of cost reduction, but undervalue quality improvements. And non-profits, under plausible assumptions, undervalue both outcomes. However, when service fees are inelastic to quality, or almost inelastic to quality, non-profits have stronger incentives for quality improvement, which, however, could still be below social welfare valuation of quality. If you want to compare for-profit, non-for-profit, and first best, it's just a comparative statics analysis of this imaginary firm that I outlined to you. And here are some results, which I will go over very quickly, and then we'll have another 15 minutes to go through the empirical part. Now, if epsilon is less than 1, in which case the market incentive to improve quality falls short of what is socially optimal, then for-profit providers would save cost too excessively. Cost savings for for-profit provider would be more than what is socially optimal, but quality improvement would be less than what is socially optimal. Okay, so, and it's worthwhile mentioning that quality shortfall is a joint outcome of full-scale financial incentives and weaker market disciplines to maintain quality. And this is, here we have an illustration of what is known as the classical second best principle, because for-profit provider faces the correct incentives to cut costs, the same as in the first best, but much weaker incentives to improve quality. And that could lead to serious distortions. And as a result, although the incentives to cut costs are accurate, because the incentives to maintain quality are weak, you have too much of cost cutting and much less of quality improvement. Proposition 2, I will probably skip it, but here is proposition 3. If the market reward for quality is sufficiently weak, then we can compare 2 providers and conclude that for-profit provider cuts cost more than non-profit and provides quality less than non-profit. So we have kind of skewed outcome, more of cost cutting, but less of of quality improvement. What is second best? Again, very quickly, and these propositions are similar to those that Schleifer, Hart, and Vishny offered in their paper. Basically, if the technology is such that the room for cost reduction, that the room for quality improvement is limited, in other words, there is not much that you can do about quality, then what is important is that for-profits have the right incentives to cut costs, and as a result, for-profits are preferable to non-profits, and they're very close to what is socially optimal. On the other hand, if there is a big room for quality improvement and narrow room for cutting costs, in that case, non-for-profit would be optimal. But I guess the most interesting part of this simple theory, and this is something that we take to the data, is comparative statics analysis with regard to the sensitivity of market reward to quality. Market reward to quality could be absent if we have a pure credence good. But in some cases, quality is more tangible, could be better established by third parties, and as a result, market reward for quality goes up. And in that case, proposition 6 holds. And according to this proposition, an increase in epsilon, which is the elasticity of market reward to quality, would increase quality and reduce cost reduction by for-profit provider. In other words, if a for-profit provider is in a market environment that puts greater premium on quality, then that would prompt, predictably, the for-profit provider to increase quality and at the same time reduce cost. And if epsilon rises all the way to 1, then the choice of the for-profit provider becomes close to socially optimal and approximates social optimum. And that cannot be said about the non-for-profit. And as a result, what we observe is that when a market is not rewarding higher quality, then it's quite possible that non-profits would be a better deal for the society than for-profits. But if there are, for some reasons, changes and the market reward goes up, becomes more sensitive to quality, then the position of these two organizational forms could reverse. And as a result, for-profits become more socially desirable, more socially optimal than the non-profit, okay? And there are some illustrations of these results. For lack of time, I will skip it. So what are the hypotheses? Based on the above, one can expect higher quality from non-profit providers than for-profit ones when the service fee is weakly related to quality. However, if the association between quality and service fees grows stronger, the quality advantage of non-profits disappear, and possibly non-profits fall behind for-profits in the quality services, and they become contesting the position of the non-profits as the second best, as the optimal choice between non-profits and for-profits. How can quality control be arranged in practice when we talk about outsourcing of social services? First, it can be done by reliable and enforceable quality contracts with adequate quality specifications. But as I explained, oftentimes this is impossible for a good number of reasons. It can be done by government regulation and oversight. It can be done through courts, litigation. Competition is, of course, a quality assurance mechanism. Providers can be driven by social responsibility, or there might be some self-regulation in the industry, and of course, media and social oversight. Going back to long-term care industry, this table shows that in this industry, the market is divided in different proportions between 3 types of providers: private for-profits, private non-profits, and public institutions. And this division depends on a good number of things. Politics plays a big role, tradition, some economic considerations, but the bottom line is that, for example, in the US, almost 70% of nursing homes are for-profit. Some much smaller number non-for-profit, and a very small small part government. In other countries, it's different, but these proportions evolve. And for example, Scandinavian countries, Sweden is very aggressively moving towards privatization of the extended care industry. How do nonprofits and for-profits compare to each other in extended care? There is a significant literature which we review in the paper. And according to this literature, by and large, nonprofit nursing homes deliver high quality services, whereas for-profit nursing homes deliver better financial results, which is kind of predictable. Now, what are the evidences of lower service quality in the case of nursing homes? The first one is, and that's a very well-known fact in nonprofit literature, that such for-profit nursing homes have greater reliance on sedatives. They prefer to sedate their patients so they don't cause much trouble, so that people stay calm. For the same reason, there is excessive reliance on physical restraint. Because people become unruly and whatnot, and that of course causes health problems such as bed sores, prolozhny for the Russian part of the audience. Oftentimes they have insufficient staff, nurses and support personnel lack qualification, and so on and so forth. And that makes perfect sense because payroll is the biggest part of the cost of nursing homes operations. There are a couple of interesting papers which I mentioned in passing. One shows that if we talk about for-profits, inside for-profit, there are some factors which affect the quality. And one is ownership and corporate governance. Some of the nonprofits are run by nonprofit chains, are operated by private equity funds, where fund managers are very keen to aggressively deliver payoff to the investments. And as a result, cost cutting in such nursing homes is particularly egregious. Informational asymmetry, a very interesting paper shows that if patients are residents are more frequently visited by their relatives, that brings about improvement in quality, simply because quality becomes more observable, and as a result, the incentive to keep quality grows up. Why nonetheless we see a lot of for-profit providers, although there are some reasons to believe that they deliver substandard care? Well, one reason is that nonprofits face capacity constraint because in theory, at least, non-for-profits are limited by the existing pools of altruism and volunteering. And this capacity constraint does not allow to catch up with the growing demand for long-term care for the elderly. And in the case of for-profits, as I explained, which is their big advantage, there are no such constraints. Now, nonprofits could target particular categories of service recipients. They oftentimes offer niche services, whereas for-profits can offer generic product for mass consumption, and this is what this industry needs quite badly these days. And last but not least, for-profits are appealing because precisely because of cost cutting, because they're cheaper for the government to fund, and they're a bit more affordable for the clients to use. I should probably skip this because I'm running out of time. There is some literature about how nonprofit industry, how long-term care industry evaluates quality, and there are some very imperfect measures of quality of quality measurement, and they're imperfect, and precisely because they're imperfect, we have this quality problem, which arises in the first instance because there is no way to reliably establish the quality of care. Okay, and now about COVID and nursing homes, and this is where the empirical part of the paper kicks in. One striking, shocking thing, I remember it firsthand, it was front page news about 2 years ago in many North American papers, US and Canadian, that nursing homes became hotspots of the pandemic. And the infection rate and mortality rate in nursing homes was extremely high. So these places were simply dangerous for the patients. And you can argue that people in nursing homes are old and they're more vulnerable to COVID, which is true, but nonetheless, the infection mortality was well above what was observed throughout the population and you can see what percentage of COVID mortality overall occurred in nursing homes in different countries. And have a look in Canada, this is shocking. First 2 months of the pandemic, 4 out of 5 people who died from COVID were nursing home patients. In the US, it was a bit weaker, but nonetheless, these numbers are quite shocking. Okay, and another thing that was immediately made clear in the media report was that mortality, COVID mortality and COVID outbreaks in for-profit nursing homes was much higher than in non-for-profits. And there are some pilot studies conducted in the US for different US states, which confirm this pattern. Now, what are causes of high mortality in nursing homes in general, but especially in for-profit nursing homes? It was non-compliance with standards and protocols of care. It's violation of sanitary and hygienic requirements due to aggressive cost cutting. Another feature which was quite specific for profits, because salaries were so low, personnel had to combine several jobs at different for-profit homes. And as a result, they immediately became infection carriers. Okay. I will skip this. In Canada, the situation became so dire that the army was asked to take care of some of the for-profit nursing homes. And what the soldiers discovered in these nursing homes was just horrible. People were really shocked. Now, the industry responded to the crisis. The disastrous performance of for-profit nursing homes during the pandemic drew attention of society, politicians, regulator, watchdogs, and so on and so forth. Now, regulation and monitoring in nursing homes steeply increased. Penalties for violations ratcheted up, and that included license withdrawals, litigation, and so on. And then, of course, once it became clear that for-profit nursing homes became dangerous for the patients, they started voting with their feet, leaving for-profits and moving to non-for-profits, and there were various proposals made. But for what is important for our story is that COVID created an entirely new market environment for the long-term care industry. It had clearly revealed italicized poor quality in for-profit nursing homes and quality advantages in non-profit nursing homes. And that was really a gigantic game changer, which affected the incentives of facility operators. COVID-19 made visible what was heretofore hidden. And as a result, COVID-19 significantly reduced the informational asymmetry. And if you recall, the informational asymmetry was the root cause of quality shortfalls among for-profit providers. COVID mortality and infection rate has become a new, reliable, and telltale quality index, observable to all key stakeholders. Bodies are visible: patients, their relatives, competitors, government agencies, media, and civil society. And that opened up new opportunities for market-based solutions. Because against the backdrop of COVID-19, care quality becomes an imperative. It's a matter of life and death, not only for patients, but also for long-term care facilities as well. And quality, as we can see now, directly affects financial performance. And the theory that I presented before suggests that market incentives, which before COVID prompted for service providers to cut quality, presently prompt them to increase quality, to restore the confidence of patients and governments. In other words, before COVID, market was a threat for quality. Now, market is something that ensures quality, because quality became much more visible, and it becomes a competitive strategy. And I'm almost out of time, but let me briefly show you the empirical part of the paper. And as I said, this is something that we work jointly with some colleagues present here. Our data source is data which is being collected from May 2020 by US government agency known as CDC, Center for Disease Control and Prevention. When it became clear that COVID affected nursing homes big way, CDC mandated that every nursing home should report to the agency on a weekly basis on a number of indicators which are required to monitor the performance of nursing homes during the pandemic. So it's a weekly reportable information, and that includes COVID infection and mortality. Now, our panel includes over 15,000 facilities across the United States. And it's for about half a year in 2020. So overall, we have 300,000 observations. So the first thing that we did was to run panel regressions with reasonable controls and fixed effects, including time fixed effect, week fixed effect, and state or county municipality fixed effect. And this panel revealed what we expected, and that is that nonprofits infection and mortality was lower than for-profits. Although, interestingly enough, this effect was not particularly strongly pronounced. It was not very significant, and it was not always robust. So what we did next, we included as a control the surrounding infection rate. In other words, we see how much of infection was in the locality where the nursing home is located, and that locality was either a state or a county, okay? And we interacted the ownership type for-profit 1, non-for-profit 0 with the infection rate in the locality. And this is where we observed a very surprising result. The interaction of infection rate and locality was highly significant. Of the locality infection rate and ownership type was highly significant and negative, which basically means that higher infection rate and locality reduced the gap between infection and mortality between for-profit and non-for-profit, which is kind of counterintuitive. We were at loss for some time to explain this, until it occurred to us that we should have a look at the trends of the infection. And this is the curve of daily new COVID cases in the United States, and our period of interest is from May 2020 until the end of the year. So basically, at that time, the US entered the second huge catastrophic COVID wave, and infection rates were rising across the country very steeply. And as a result, what we see here as interaction of type with infection rate, in fact, was, as I will show in a second, interaction between type and time, because infection rate was correlated across the country with time. Exactly, indeed, when we include time fixed effect, which is number of the week, and also interact number of the week with the type of facility, we observe significant. Our primary columns of interest is 1 and 4. Ignore second and third. We observe this negative correlation. We observe a significant negative coefficient, which means basically that over time, the difference in the performance of for-profits and non-for-profit nursing homes was getting narrower and narrower. And this is perfectly consistent with the theory which I presented before, because over time, the quality became much more tangible, palpable, observable. And as a result, the market incentives that before COVID prompted for-profit providers to aggressively cut quality, now the very same market incentives, they turn into a blessing from a curse, and now they are prompting for-profits to more aggressively increase quality. And this diagram shows it quite clearly. This is the passage of time, and this is the average marginal effect for mortality and for the infection of for-profit organization. And you can see that it was first statistically significantly positive. At the end, it became insignificant and largely negative. And in the case of infection, it starts from very high and positive to statistically insignificant. So that's pretty much it. I have concluding comments, which are as follows. COVID-19 pandemic made care quality in nursing homes more observable and easier to ascertain. And as a result, it has produced powerful market incentives to provide quality care. So for-profits had the right market incentives to cut costs, but had two extremely weak market incentives to provide quality. Now that there is some catching up with the market incentives for quality, it comes as no surprise that for-profits emerge as good competitors, as good providers, more or less on par, and sometimes even better than non-for-profit. And this is what it says here. For-profit nursing homes, which are more sensitive to market incentives, responded to the new incentives more vigorously. And therefore they reveal the potential of market-based, market-grounded mechanisms and incentives in the long-term care industry under reduced informational asymmetry. Now, the COVID is not going to be with us forever, hopefully. And the question is how this effect can be sustained past the pandemic. All we can say is that to sustain such effect and effectively use private capital in the nursing home industry after COVID-19, we need new transparency and accountability measures that would ensure adequate quality controls by means that are somewhat less deadly than the coronavirus. Thanks.
Thank you very much, Leonid, for the very interesting presentation. So I think now it's time for the audience for questions or comments. So if there are any, please go ahead.
Leonid, yes, yep. Just a very maybe simple question in general. About your model, how much your results are affected by the definition of innovation you do adopt? Because it seems to me that your innovation is a reduction in cost and increase in quality. But you can define innovation just, one of the two or in a different combination of. So is it this assumption or is this definition of innovation crucial for your results?
Well, excuse me, I guess, yes, it's essential, but I think it seems to be natural and reasonable to me, because why do we innovate in general? On the one hand, you do it to reduce cost, on the other hand, to improve quality. What else? The end results of innovation. And you can be concerned in different proportions about cost reduction and or quality improvement, but you would not innovate for the sake of innovating. And Paola, please notice I'm not looking under the hood. I'm not talking about the specifics of innovation. I'm talking about the outcomes of the innovation. Mm-hmm. And how these outcomes are produced. That's a separate matter, and I guess that's more or less what you're asking about. So it's kind of a black box, but the ultimate objective of innovation is to improve your product and or to make a product cheaper, I guess. Unless you're coming up with a completely new product, but in the case of long-term care industry, this is lesser the case. And what is important for us is to observe that different ownership types affect the incentives to achieve these two outcomes, one of which is cutting costs, and another one is to improving quality. So that's perhaps another thing to mention in regard to your question is that if you look at the paper of Hart, Schleifer, and Vishny, from which we departed, they work with very specific types of innovation. Basically, they consider two types of innovation. Yeah. One type of innovation improves quality but cuts cost. So there is a trade-off. Yeah. And the second type of innovation only improves quality. And that seems to be a little bit artificial to us. Mm-hmm. And as a result, in our model, we just have a general pool of innovations. And each combination comes with a particular cost to develop and to produce. But our approach absorbs, so Schleifer and others' theory is a special case of ours. We generalize, and that makes results more compelling, I think, and also a bit simpler, easier to prove than in their case.
Yeah, indeed, it is exactly referring to the paper, to that paper, the literature that the question comes. Also because, and the other point is that considering the health sector, it could be that you have innovation not really reducing cost, but just because you make a better condition for the health, the people health. So
okay, well,
yeah.
that's quality.
Yeah, exactly.
All of that is quality, because quality is a complex matter.
Okay. Exactly.
All right, so that is still in
yes, in your
purview.
Okay. Thank you very much, Leonid.
Absolutely, yeah, of course.
Please, Anton, go ahead.
Yeah, thank you so much for this very interesting presentation. And my question is about the nature of the goods after this market transformation. Can we say now that these goods, which are provided by for-profit nursing homes, are they still credence goods, or will they stop being credence goods?
Anton, it really depends. Again, the thing to keep in mind is that many people in these nursing homes are at their advanced stages, right? And as a result, they are not as agile, not as active, not as aggressive. They have serious health issues. Sadly, quite a few of them have dementia and other mental health issues. And as a result, at least some of them cannot properly evaluate the quality of services. And some less scrupulous providers of these services can take advantage of this fact. And for example, if someone is in good health, mentally, physically, and sees something wrong and complains, they will simply dismiss it by saying that this grandpa is out of his mind, he's not in full control of his faculties, and his complaint should not be taken very seriously. And oftentimes guardians and relatives agree. And so this is why quality ascertainment is not as straightforward in some other cases. And as you can see, many of these places were able to get away with pretty poor performance until the pandemic revealed that it was really something completely unacceptable. And quality became much more tangible and measurable, because quality was measured in infections and in bodies of dead people.
Thank you so much.
Yeah.
Any more? Yes, Timur, please.
Yes, thank you. Yes, I also have a question about the model, sort of clarification. Okay. So you have this multiplier epsilon, which is less than 1. And does it mean that a customer can only underestimate the quality, or is it both way? He can overestimate and underestimate the true quality of the service?
Well, it's not a matter of overestimating or underestimating quality. It's a matter of the extent to which market reward depends on quality. It's the elasticity of compensation that the provider gets, irrespective of the type of ownership of this provider to the quality. If quality is completely unmeasurable, then a for-profit provider will not get any reward for increasing quality. Non-for-profit provider will get some reward for increased quality because of this warm glow and sense of mission and purpose. And as a result, in such case, non-for-profit provider will have a slightly stronger incentive to deliver quality. Also, another component is that non-for-profit provider, it does not mean that non-for-profit provider wants, that for-profit provider wants bad quality for the sake of bad quality. They're not bad people, but they are concerned about the financial bottom line. And the best way to improve financial results, if market reward is not sensitive to quality, is to cut cost. But cost cutting is easier when quality is lower. So lower quality is a byproduct of the incentive to cut cost. And this is what is happening in the case of a for-profit provider. So it's unlikely that if I can, let me go to the formula. One moment, Timur. Here we go. See, Q is a quality improvement. And the way the quality improvement is measured, we measure it in the contribution of the service to social welfare in monetary terms. So if epsilon equals 1, then all the gains from quality improvement are passed to the provider. That is unlikely, because these gains will probably be split, right? If I improve my quality, then I should get a part of that quality improvement, maybe 50-50, maybe not. That's what the paper by Schleifer and others argued about. So epsilon should be less than 1, but the question is how much less? And in the extreme case of a complete credence good, it's just 0. And in that case, we have serious troubles with for-profit providers, and these troubles are not as acute in the case of non-for-profit providers. So that's basically all I can say in response. I'm not sure if I answered the question directly, but
yes, thank you.
That's my best shake.
Thanks. Yeah, and one more question about the empirical part.
Okay.
Have you tried some placebo exercises with other periods of time, like before COVID mortality, or mortality not from COVID, but from other diseases during the pandemic?
Good, yeah, good observation, Timur. We cannot do much before COVID because CDC started collecting this data after COVID. Okay, but we can certainly run some analysis for later periods because our empirical part ended at the end of 2000. But COVID kind of subsided sometimes, and so sure, yes, this kind of placebo would be quite useful, and especially because CDC data allow us to measure mortality overall and COVID mortality in particular. So good point. Thanks, Timur. Duly noted. Appreciate it.
Yeah, and that would be more more persuasive for your results, I think. To be sure that you're not capturing that something that happened at this moment as well.
Yeah, well, we have time fixed effects, so that addresses that concern in part. But I agree that that would be an improvement of the empirical strategy. So I hope Ivan is still here and he's taking notes. If not, I'll communicate it to him.
Any further questions from the audience? I see none. Well, I have one last question, Leonid.
Sure.
So, well, I guess the answer, I guess, is no, but I just wanted to ask, like, are there any concerns for like self-selection? I don't know, like maybe richer people going to some, for example, to non-profit organizations, and maybe they were healthier, and maybe that's why at the beginning there was less mortality. Are there any concerns of the sort, or not really?
Well, that's a question of controls. And I do believe that we control for this kind of things. So we have some additional information about the institutions. And one is whether this institution accepts Medicare and Medicaid payments. And basically, poorer people rely on this support. So in other words, really wealthy people who live in exquisite, luxurious nursing homes, they pay out of pocket. So we have ways and means to indirectly control for that effect, and these controls do not affect the results. So although I'm not sure if we have direct measures of wealth of the people who select different institutions. Financial conditions between non-profit and for-profit are comparable to each other. It's a competitive market, right? So it does not mean that poorer people go to non-profits. Actually, oftentimes poorer people go to for-profits because, as I explained, for-profits are able to offer cheaper generic services, more basic, more sort of bottom line. And there is no clear correlation between the wealth of patients and the type of the institutions. But that's a good point. We'll need to think more about this.
Thanks. So any further questions? Okay, so well, thank you once more, Leonid, for the very interesting presentation. I think that has made us all think a bit more about this.
Okay,
And yes, and well, like next seminar at the moment would be Timur presenting on the 19th of May. Although if we have some change of schedule, you will be receive the information in advance as usual. So thanks everyone in the audience for this interesting and active seminar. And see you in a few weeks. And yeah, have
Thanks
a
very
nice
much,
evening.
Okay.